Dr. Lee earned her doctorate of medicine and completed her residency in internal medicine at the University of British Columbia, and then went on to obtain her training in hematology and thrombosis and her Master's of Science in Health Research Methodology at McMaster University. And of course, Dr. Lee is an active member of Thrombosis Canada. So with that, I'll turn it over to Dr. Lee to start the presentation. But again, I'd ask everybody to mute their phones if possible.
Hi, thank you, Sudeep. Thank you, everyone. I know everybody's busy, and so thank you very much for sharing your hour and a half with us. We have about 40 slides. We covered the talk, the area. So if you can hold off on questions, we can address everything at the end. But again, if there's anything urgent, please interrupt, because I don't think it's a very big group, so we can certainly do that. So to start with, I just want to review my disclosures. In terms of potential conflicts of interest, I do sit on an advisory board on a steering committee for study with Bayer, and I have received honoraria or grants from Bayer, BMS, Leo Pharma, Pfizer, and Servier. All of these companies market low molecular weight heparins or direct oral anticoagulants, and I have participated in clinical trials with Daiichi Sankyo, BMS, Pfizer in the past 2 years. So before I go into the data about treatment, just want to bring everybody sort of onto the same page in terms of the importance of cancer-associated thrombosis and some of the background epidemiological information. So I think many of you know the incidence of thrombosis in the general population is approximately 1 in 1,000. So a recent study showed that it's approximately 117 per 100,000. But if you look at the cancer population, all right, cancer patients have about a 4 to 6-fold risk of thrombosis, depending on whether the patient is also receiving chemotherapy. And this risk also fluctuates over time as well and will vary depending on the kind of cancer treatment the patient is receiving. And so if you sort of combine this, a very rough estimate of the annual incidence of venous thrombosis in cancer patients is about 1 in 200. And given the prevalence of cancer, given our aging population, cancer-associated thrombosis obviously is a growing problem for us. If you look at the incidence, the graph shows you the fluctuation in the risk of thrombosis in cancer patients as they're going through their course of disease with cancer. So, for example, when they're first diagnosed, the incidence of thrombosis is much higher than later in their course. If they're hospitalized, if they undergo surgery, and if they reach remission or have a complete response, you can see then the risk dips quite low again, almost back to the general population. However, if they develop recurrence or progression or metastatic disease, and certainly close to the end of life, the risk of thrombosis goes back up again. So clearly, cancer patients have a very diverse, fluctuating course over time. But if you look at overall, it's been estimated based on a recent study published in 2017 that the lifetime risk of getting thrombosis via a cancer patient is about 6% annually. And so again, this is a much higher percentage compared to 1 in 1,000 in patients without cancer. If you look at the incidence of thrombosis by cancer type, you can see that patients with pancreatic cancer has a particularly high risk of thrombosis. We certainly see that in our thrombosis clinic, whereas patients with breast cancer or bladder cancer, for example, have a lower risk. So when we see patients with the high-risk cancers, we're more thinking about can we reduce the risk in these patients, and recently there are prophylaxis studies concentrating or focusing on particularly high-risk patients, and hopefully we will have the results actually of 2 large randomized trials later this year that will look at whether thromboprophylaxis in high-risk populations, such as those with pancreatic cancer, will actually benefit from thromboprophylaxis. If you look at, though, who are the types of cancer patients coming to thrombosis clinic with cancer, it actually turns out that prostate and breast are still the most common, mainly because of the high prevalence of these cancers in the general population. All right, so even though breast and prostate are not the most thrombogenic tumors, all right, they are the types of patients we tend to see in the thrombosis clinic because of the underlying risk of these particular cancers. But as you can see here, even for pancreatic and stomach cancer, although these are relatively rare cancer types, we do see them because they're so thrombogenic. Another concern about thrombosis in cancer patients is that thrombosis is actually the second leading cause of death in patients with cancer, only secondary to cancer progression. And this ties with infection, for example. And the annual death rate for thrombosis in cancer patients is 448 per 100,000. So this represents about a 47-fold over the general population. And so, you know, there's been a lot of concern about, well, is this because we are not treating patients with cancer and thrombosis appropriately or aggressively enough so that they're prematurely dying of thrombotic events, or is thrombosis really part of the end of a cancer journey? So in patients with end-stage cancer, they're likely to develop thrombosis regardless. So I think the truth is probably somewhere in the middle, and so we do want to focus on how we can best treat cancer patients when they do develop thrombotic events to help reduce the likelihood of a premature death in patients with cancer. So as all of you know, the CHEST guidelines for many years have recommended low molecular weight heparin as being the standard treatment for patients with cancer-associated thrombosis. And in the last version in 2016, it still recommended low molecular weight heparin, all right, over all the other alternatives or options, including vitamin K antagonist therapy and all the direct oral anticoagulants. However, based on the most recent randomized control trials, I suspect guidelines will be changing these recommendations, and I'm going to now go over the details of these two randomized trials with you. So the first trial is the Hokusai VTE-Cancer study, and this was published in the New England Journal in December 2017. This was a large, multi-center, open-label randomized study which randomized cancer patients to receive standard low molecular weight heparin therapy using the CLOT regimen, so with dalteparin throughout treatment for 6 months and up to 12 months, or they received edoxaban therapy according to the standard way edoxaban is given, which is the first 5 days patients are given low molecular weight heparins, and then they switch to edoxaban 60 milligrams once a day. Now, some of the patients in this study received a lower dose of edoxaban based on a concern for bleeding, and namely these were patients who had a lower body weight of 60 kilos or less, if they had mild to moderate renal insufficiency with a creatinine clearance of 30 to 50, and also if they were receiving a potent peak glycoprotein inhibitor. So approximately 25% of the population had a reduced dose of edoxaban, but these patients did not receive a reduced dose of dalteparin. Overall, the primary outcome of the study was a composite of recurrent thrombosis or major bleeding, and regardless of the duration of therapy, so the patients were followed all the way up to month 12, whether they stopped or continued on anticoagulation. And the secondary outcomes were recurrent thrombosis, major bleeding, clinically relevant bleeding, and all-cause death. So this is the first time in a thrombosis study where we actually did a composite outcome of recurrent thrombosis or major bleeding. As you know, traditionally in thrombosis studies, we usually look at recurrent thrombosis as being the primary outcome. If you look at the patients enrolled in this study, you can see the two groups were very well balanced in terms of their age, gender, the type of thrombosis. So vast majority had PE. Vast majority also had symptomatic thrombosis, but you can see approximately 30% of these patients had incidental thrombosis. Obviously, most of the patients had active cancer, and the 2% of patients that didn't have active cancer had cancer diagnosed within the last 2 years. About 53% of the patients had metastatic disease, and you can see, though, there was a difference in treatment duration where the patients who received dalteparin had about 27 days less treatment than the edoxaban arm. And this difference was largely due to a patient preference to stop anticoagulation and stopping the injections at about 6 months. And this is one of the limitations of the study in terms of differences in treatment exposure. If you look at the types of cancers, again, very well representative of the types of cancers we see in patients with cancer-associated thrombosis. The most common tumor types were colorectal, lung, and genitourinary. And you can see patients with hematological malignancy represented about 10%, and this is fairly consistent with other studies as well. And most of these patients with hematological malignancies had either myeloma or lymphoma. If you now look at this slide, it actually breaks down into the types of chemotherapies that the patients received. Once again, due to the large, sample size of the study, the patients are fairly well balanced in terms of the types of treatment they received, but of note, one treatment that is sort of missing in here is immunotherapy, and really this just reflects the, when this study was done, immunotherapy was still not sort of the major player, but clearly this is rapidly changing over time. So it's something to keep in mind when we are using direct oral anticoagulants in patients with immunotherapy. This slide shows you the primary outcome of the study. Again, this is the time to the first occurrence of a recurrent thrombosis or major bleeding. You can see there's really no difference between the two treatment groups. All right, the two curves are, almost identical, and you can see the study met significant statistical significance in terms of non-inferiority with a p-value of 0.006. If you now, though, look at the primary outcome in a little bit more detail, remembering that patients who were assigned to dalteparin actually received a shorter duration of treatment because of patient preference. So if you look at the primary analysis, there was a slight difference numerically, but statistically, obviously, non-inferior, but probably no difference. But if you look at the first 6 months where patients, most of the patients completed 6 months of therapy, and also per protocol where they looked at the risk of the primary outcome while the patients will remain on treatment, there's really no difference between the two regimens. If you break down the primary outcome into the secondary outcomes of recurrent thrombosis, major bleeding, and event-free survival, you can see that for recurrent thrombosis, again, there is no difference in overall recurrence. You can see the curve sort of separates actually only after about the first 3 months, and there seems to be a hiccup with the dalteparin arm, which is the top graph there, the top line there. But overall, there's no statistical significant difference in terms of recurrent thrombosis. However, if you look at major bleeding, though, the two curves do separate and seems to separate at the very onset when patients started edoxaban therapy, and this difference was statistically significant. And finally, there was no event-free survival, so it's nice to know that basically, even though there was a increased risk of major bleeding overall, this did not lead to a worse survival. If we drill down on the risk of major bleeding and the severity of these bleeding, you can see majority of the bleeding events actually occurred in the upper GI tract, and this occurred primarily in patients with GI cancer as well, and this was even in patients with, say, colorectal cancer, the risk of upper GI bleeding was higher. If you look at the types or the severity of bleeding, this was a score that was introduced to sort of break down the types of major bleeding. You can see there's also no difference in the category 3 types of bleeding. These are bleedings that required sort of considered urgent or emergent intervention, whereas grade 2 types of bleeding there were more in the edoxaban arm, and these were primarily bleeding that did require intervention, obviously, transfusions, hospitalization, intervention, but they were not considered sort of urgent or potentially life-threatening. Looking at other key outcomes of the study, I've already highlighted that there was a difference in the length of therapy. So again, the median duration of treatment was significantly shorter in the dalteparin arm, and this was largely due to patient preference. So if you could see at 6 months, only 4% of the patients on edoxaban stopped therapy, whereas almost 15% of the patients stopped dalteparin. So, clearly it's not rocket science, that patients would prefer not to continue injections, but because of this differential in treatment duration, it does affect in terms of the balance of randomization. And so it may partially explain why the efficacy curves, if you remember, the recurrent VTE curve were virtually identical up to about 3 months and then starts to separate after. And this may reflect that, again, there was a difference in the duration of therapy in the two groups. In terms of major bleeding, if you look on the bottom of this slide, you can see if in the patients who had GI malignancies, the risk of major bleeding was actually 13.2% for edoxaban versus only 2.4% for dalteparin, and this was statistically significant. So it's very reflective of sort of the signal we see in non-cancer patients as well, where GI bleeding is a particular problem, and in cancer patients, those with GI cancers also have a really higher risk. So in terms of the limitations of the study, overall it is a very well done, large randomized control trial, but the dose reduction within the group who had a lower body weight, renal impairment, and the use of P-glycoprotein inhibitor is a bit of a hiccup in terms of even in this group of patients who had a dose reduction, these patients still had a higher risk of bleeding compared to patients who received full dose dalteparin therapy. We've already talked about drug exposure, where there was a shorter duration of dalteparin use, and also there's no report on what's the alternative anticoagulant therapy used in the patients who say stopped dalteparin or stopped edoxaban prematurely. So for example, if all of these patients switch to vitamin K antagonist therapy, which we know, are not as effective as low molecular weight heparin, then the event rates in terms of recurrent thrombosis may be higher than otherwise anticipated. And finally, we do not have patients who are receiving novel anti-cancer therapies, so really no experience with how direct oral anticoagulant may work in patients with immunotherapy. And this is a group in whom there is some concern about a high incidence of colitis or diarrhea, for example, and that may have an impact on the effectiveness as well as the safety of an oral drug. So let's move on to the next randomized control trial that also gave us information on how a direct oral anticoagulant would work in patients with cancer-associated thrombosis. So very much like the Hokusai cancer study, in this trial, patients with cancer-associated thrombosis were randomized to either standard therapy with dalteparin using the clot regimen or to standard therapy with rivaroxaban. And the rivaroxaban regimen used here is the standard we use in all patients with thrombosis now, starting with rivaroxaban 15 milligrams twice a day for 3 weeks, and then step down to 20 milligrams once a day. Now, this study treated these patients for 6 months, and then there was a second phase where they were going to randomize patients again to either continue with rivaroxaban or to placebo. And this second part of the trial was really designed to look at duration of anticoagulant therapy. The primary outcome with this study was more traditional in terms of looking at recurrent thrombosis at 6 months, and the secondary outcomes were major bleeding and clinically relevant bleeding. So similar to Hokusai, but somewhat different in terms of this second phase addition. Now, In terms of the primary outcome, this is very standard, looking at recurrent proximal DVT or PE. And here, though, they included symptomatic as well as incidental thrombosis. And in contrast to Hokusai study and all previous cancer-associated thrombosis study, SELECT-D also included unusual site thrombosis in their primary outcomes. So this included patients with upper limb thrombosis, splanchnic vein thrombosis, and so on. And there were a few events in this study. So again, the results may not be completely, comparable or can be compared to other studies where unusual site thromboses were not included. Because SELECT-D was designed as a pilot study to provide point estimates of the risk of recurrent thrombosis, and this was also an investigator-initiated study, the study protocol did not specify central blinded adjudication of suspected VTE events. And consequently, we do not know if some events that may have been locally said to be a negative event or could have been a false negative, and so they were missed. But after the study was completed, there was adjudication by a committee that was blinded to the treatment outcome. But this sort of post hoc adjudication does not really mitigate the potential bias when we're missing suspected VTE events. When we look at the study design overall, there were further sort of problems or limitations to the study design. So because of the second phase where they were randomizing patients to duration of therapy, limited enrollment, a lot of patients did not want to participate in that second part. They decided in September 2016 to actually close phase 2 after about only 92 patients were recruited after 2 years. And so they decided to just focus on phase 1. And when they decided to close phase 2, they also reduced the sample size from the original estimate of 520 down to a total of only 400 patients. Another amendment that was made during the study was that the DSMB noted there was an excessive number of patients with major bleeding in the rivaroxaban arm in those patients who had gastroesophageal or esophageal cancer. So in order to really maintain or certainly make sure that the patient safety was a priority, they recommended stopping enrollment of patients with gastroesophageal and esophageal cancers due to the excessive bleeding. So consequently, this study in some way underrepresented this group, and because this group also has a higher risk of recurrence as well as a higher risk of bleeding, it makes it very difficult again to compare the risk estimates or the outcome in this study compared to previous studies. If we look at the patients who were enrolled in the study, approximately 200 patients were enrolled in each arm, and you can see that the groups were pretty well balanced in terms of their age, gender, their BMI, whether they had metastatic cancer, and whether they were receiving cancer treatment. All right, most of the patients were actually doing quite well with a good performance status of 0 or 1. So you can see approximately 70% of the patients were doing very well. And similar to the Hokusai study, SELECT-D also enrolled patients who had incidental thrombosis. So in Hokusai, there were approximately a third of patients had incidental thrombosis, but in the SELECT-D, you can see just over half of the patients, in fact, had incidental thrombosis. So again, these are characteristics of this trial and the Hokusai that makes it difficult to compare to, say, CLOT and CATCH, where only patients with symptomatic thrombosis were enrolled. So at the end, 430 patients were enrolled in the SELECT-D study. The second randomization phase, as you recall, was deemed not feasible, so we're really only focusing on the first phase of the study. And they also decided not to proceed to a larger study because of the failure of phase 2. This slide, this table here on this slide summarizes the 6-month outcomes in terms of recurrent thrombosis, major bleeding, clinically relevant non-major bleeding, and the combined of major and clinically relevant non-major bleeding. So you can see there were some certainly numerical differences between these outcomes. There were more recurrent thrombosis associated with dalteparin, but there was more bleeding associated with rivaroxaban. So this graph shows you the basically the primary outcome in terms of time to recurrent thrombosis within the 6 months. You can see there seems to be somewhat of a separation of the curves, and this difference was in fact statistically significant. I think the next slide will show you what the major bleeding is. Yeah, so in terms of major bleeding, there was also a separation of the two curves, but this was not statistically significant because this actual difference here is actually quite small. So in terms of the limitations of the SELECT-D study, this was a pilot study design. It was not aimed to detect a difference, but it was supposed to provide point estimates of recurrent thrombosis to help design a larger study. And with this, the study was still able to detect a difference in the primary outcome of recurrent thrombosis, but remember that outcome did not undergo central blinded adjudication during the study. So there may be still some uncertainty about these point estimates. There was also a change in the study design, if you recall, in terms of the closing phase 2 as well as reducing sample size. And finally, there was a selection of patients because patients who had gastroesophageal and esophageal cancers were excluded after they noted an excessive number of bleeding events, particularly in the rivaroxaban arm. So if you keep this in mind, then we know that it is likely that the major bleeding events for the total study will be lower than other studies that didn't exclude this population, and may also lower the major bleeding event in the rivaroxaban arm because this was the group that had more bleeding. If you combine the results of the two studies, all right, overall, this is a meta-analysis that was published earlier this year, you can see that certainly it suggests both edoxaban and rivaroxaban seems to be associated with a low risk of recurrent thrombosis, all right? The p-value was not statistically significant here. And however, if you look at major bleeding, this reduction in VTE seems to be offset by a significant increase in major bleeding. Sorry, I'm just, okay. Sorry, my mouse doesn't seem to be very sensitive to the slide advancement, so that's why there's some pauses in between these slides. So with these results in mind, it certainly seems that direct oral anticoagulants are non-inferior to low molecular weight heparin. Overall performance seems to be the same when you lump in recurrent thrombosis and major bleeding together. Are there any other things we should keep in mind before using, that may favor us using one or the other agents? So one of the big items that we do keep in mind is drug-drug interactions. This is not a concern at all for low molecular weight heparin, and certainly in some ways make this more convenient to use. However, for direct oral anticoagulants, there are some drug-drug interactions that we do have to keep in mind. So depending on the type of direct oral anticoagulant, you can see that they are metabolized by either CYP3A4 or also by P-glycoprotein transport pathway. So any other drugs, all right, that are inhibitors or inducers of these two enzymatic pathways will have an impact on the drug levels of the direct oral anticoagulants. And these drug-drug interactions are very difficult to predict in terms of the overall impact. And also, even if there are theoretical drug-drug interactions, we do not know whether the lowering or the increased levels of the direct oral anticoagulant will translate to a clinically important difference. This slide shows you some of the agents that are known to have effects on CYP3A4 and P-glycoprotein. So you can see if a cancer patient receiving any of these drugs, all right, are now placed on a direct oral anticoagulant, there may be some concern about the direct oral anticoagulant being more effective or less effective, more bleeding or less bleeding. So again, it's just something to keep in mind. So it's very important to talk to your pharmacist and sort of review potential drug-drug interactions before you prescribe a DOAC in cancer patients. Besides drug-drug interactions, are there any other factors we want to think about? Well, for me, I always think about the burden of the cancer and the burden of the thrombosis, because in both Hokusai and in SELECT-D, most of the cancer patients were quite stable, all right? Those studies also did not include patients with, say, submassive PE and in patients who required thrombolysis or had extensive PE. So we're still a little bit uncertain about how direct oral anticoagulants are going to be in these patients. Certainly in patients with renal impairment, we have a lot more experience now with low molecular weight heparin, but this is still very limited in patients with direct oral anticoagulants. And if you recall in the Hokusai study, patients with a creatinine clearance of 30 to 50 had received a reduced dose of edoxaban, but despite this dose reduction, these patients still had a high risk of bleeding compared to patients who received full dose dalteparin. Finally, in terms of GI surgery absorption of GI absorption disorders, this is a problem for any oral drug, clearly, and in patients receiving DOACs, then we need to be aware so that you may need to monitor them closely, and perhaps in patients who really have significant GI toxicity, say from immunotherapy, this may not be a good combination or it's not a good time to use direct oral anticoagulants in that setting. Patients with extreme body weight, still concerned for low molecular weight heparin, and more so with direct oral anticoagulants as well if they are significantly underweight or significantly lower weight. With low molecular weight heparin, we do have some experience that because the dosing is weight adjusted, there may be less concern than with direct oral anticoagulants. And finally, we still need more experience with direct oral anticoagulants in patients who are receiving ASA, other antiplatelet agents, or other pre-existing conditions such as liver impairment, congestive heart failure, that may also affect how these drugs are metabolized. And finally, really important when we have two therapies that are very, very similar or comparable, that we consider patient preferences, all right? We need to inform the patients of the risks and benefits, that there's no difference in efficacy perhaps, but there's a signal for increased risk of bleeding, particularly in GI cancers. And we also have to look into the differences in terms of drug coverage and accessibility. So in BC, for example, where low molecular weight heparin is covered, I do have patients who actually prefer to stay on low molecular weight heparin injections because it's free as opposed to pay out of pocket for direct oral anticoagulants. So clearly this is going to be a changing landscape in terms of funding by the different provinces over time as well. And but this is something to really think about before you prescribe one or the other. And I think as physicians, we always forget that our perspective may be different from patients, and in a number of qualitative studies, it's actually been shown if you ask cancer patients what is their preference for an anticoagulant, their number one major characteristic for the treatment is that it does not interfere with their cancer treatment. So that is above and any other considerations, because to them that is the most important, is their cancer treatment. Then they look at efficacy and then safety, and then finally they look at the route of administration. So they don't really care if the drug is going to be a pill or an injection, all right? If if the treatment is going to interfere with their cancer treatment, or if the treatment is not going to be safe or effective. So again, we need to remember and keep this in mind when we discuss with patients. So with all of this in mind, how do we individualize therapy? So we can sort of individualize the approach per patient in terms of looking at drug-drug interactions, where they have nausea, vomiting, or other kinds of GI toxicity, all right? Because these problems may certainly favor low molecular weight heparin because we don't have to worry about it. However, if we look at an overall risk-benefit ratio, all right, well, there is perhaps a reduced risk of recurrent thrombosis associated with DOACs, but this is, at the cost of a higher risk of bleeding. But remember, overall, there was no difference in mortality in the two groups. So recently, the Subcommittee on Hemostasis and Malignancy from ISTH published these guidelines to help guide clinical practice. So they recommended that the use of DOACs is suggested for cancer patients with an acute diagnosis of thrombosis if they have a low risk of bleeding and if they don't have any drug-drug interactions with their current systemic therapy. They do recognize that edoxaban and rivaroxaban are the only direct oral anticoagulants with current randomized trial evidence. So if you are going to be using a direct oral anticoagulant, it is recommended you use either edoxaban or rivaroxaban as opposed to the other agents like dabigatran and apixaban, where we don't have head-to-head comparison with low molecular weight heparin yet. And certainly, low molecular weight heparin remains an acceptable alternative in patients with cancer-associated thrombosis. And low molecular weight heparins, in fact, are still suggested for cancer patients with acute thrombosis and a high risk of bleeding. And these patients are patients who probably have a luminal GI tumor, all right, if the primary is still intact, not resected, if they have active mucosal lesions, all right, such as ulcers, gastritis, colitis, that type of thing, because clearly these are the patients who are going to be at the highest risk of bleeding. However, they do say that DOACs is an acceptable alternative if there is no drug-drug interaction, all right, with the therapy, and clearly if your patient accepts the increased risk of bleeding if they prefer not to do injections. So again, in my practice, I fully disclose to my GI cancer patients that, these direct oral anticoagulants are associated with a higher risk of bleeding. However, they can still use this drug as long as they will accept that risk if, for example, they cannot afford low molecular weight heparin or if they do not want to do injections. And most recently, Canadian expert consensus, this group of us, we got together and basically also, reviewed the evidence and came up with some recommendations that really reflects more the Canadian sort of practice. And this just came out in publication actually a week ago. And the next slide will show you basically sort of the overall recommendation. And this is in some ways far more prescriptive compared to the ISTH guidelines, and it really sort of illustrates a way to think through how you're going to treat cancer patients with thrombosis. So looking at the algorithm here, in patients with cancer-associated thrombosis, the first question to ask is, does this patient have a risk of bleeding? So we considered the usual risk factors, such as a previous risk of GI bleeding, thrombocytopenia, renal impairment, and so on. So if the patient has a high risk of bleeding, then low molecular weight heparin is recommended. Now, if the patient does not have a high risk of bleeding, what kind of cancers do they have? If the patient has an active GI or GU cancer, then low molecular weight heparin, again, is recommended because of the signal for increased bleeding in these tumor groups from both Hokusai and SELECT-D. Now, if the patient doesn't have a high risk of bleeding, does not have a GI-GU cancer, then you should ask, are there drug-drug interactions, all right? And again, you should really review this with your pharmacists who are far more knowledgeable about the types of chemotherapeutic agents and, and can look up and try to estimate if there are going to be significant drug-drug interactions. And if there is, then again, low molecular weight heparin is the preferred therapy. But if the patients are able to sort of escape all three of these strikes, then a direct oral anticoagulant with either edoxaban or rivaroxaban would be a very good option. Once you decide on the treatment, you should really reassess these patients every 3 months, all right, because cancer patients' conditions can change fairly rapidly. And every time you review, you should always ask, is the cancer active? Because if the cancer is not active, you should really consider stopping anticoagulant therapy. But if they're active, then you really need to go back to the top of the algorithm again, because patients who didn't have a bleeding problem before may now have had, a bleeding event. So then you may want to switch therapy at this point. So again, this is an algorithm that a number of us put together, and certainly this needs to be, implemented, considering patient preferences and drug availability or accessibility as well. So, in summary then, cancer-associated venous thromboembolism, it is associated with high morbidity and mortality. And hopefully, if we provide patients with optimal anticoagulant treatment, we will help to prevent premature mortality in these patients. Thankfully, we now have multiple anticoagulant options, all right? So low molecular weight heparins, edoxaban, and rivaroxaban should be considered in all of your patients, all right? And I think even warfarin therapy should be considered, particularly, after the first 6 months of treatment, where we still don't have any data on what's the optimal therapy in these patients. You should consider the risk of recurrence, bleeding, and patient preference anytime you're prescribing anticoagulant therapy, and frequent reassessment clearly is very important for tailoring therapy in this very high risk and very heterogeneous group. So thank you very much for your attention, and I'm going to turn this back to Sudeep, who can handle the questions. And I don't actually see any chat things on here, but
yes.
If anybody has any questions, please feel free to.
And I'd like to just take this opportunity to thank Agnes for excellent overview of the very recent evidence in this area. So again, if anybody has any questions, please either enter them in the chat window, and I think because it's a small group, you can unmute your phone and ask it, and we can try and handle it that way. I will just start with a question of my own. The algorithm really does highlight some risk factors for bleeding, including a creatinine clearance of 30 to 50. One issue is, what do we do with the people who have a creatinine clearance less than 30, say that 15 to 30 range? Some of the DOACs, like rivaroxaban, have expanded their monograph to include, patients with a creatinine clearance over 15, but some of the cancer-associated thrombosis studies suggest an increased risk of bleeding in these patients. How would you manage a patient with a creatinine clearance between 15 and 30 with a new DVT, for example?
Yeah, so that's an excellent question, and thankfully these patients aren't that common, but when they do happen, I actually prefer using low molecular weight heparin over warfarin in this setting as well. So both from CLOT and CATCH, there are now sort of post-hoc subgroup analysis looking at the patients with renal impairment, and it certainly shows that both dalteparin and tinzaparin used in the CLOT and CATCH studies, respectively, did not increase the risk of bleeding compared to warfarin. So actually, if you have patients with severe renal impairment, low molecular weight heparin is still very safe and effective. I do have access to anti-10A monitoring here in Vancouver, and I think most people will have access to them. And so what I usually do is I start these patients on a weight-adjusted dose, and then I check their anti-10A level at trough about a week later. If there is no changes, then I check it again at the 1 month mark. And again, if there's no changes, then I check it again for 2 months. And really, if there's no bioaccumulation, as shown by their 10A levels, the patient and their renal function is sort of stable at that fat level, then I have not seen any problems in terms of bleeding. And even though there is some monitoring involved, it is certainly still far easier than warfarin therapy, obviously. And in patients with this severe renal impairment, I find that warfarin control is also seems to be worse. And I don't know, maybe because it's the diet of these patients or because some of them, are on dialysis, that they actually fluctuate. So locally, we've had a lot of experience with using low molecular weight heparin in patients even on dialysis. Now, the direct oral anticoagulants, I know they have been approved for this severe renal impairment group, but there's really very little clinical evidence that they are safe and effective. And if you look at the Hokusai study in the appendix of the New England Journal, you can see even for the Hokusai group, the edoxaban group in the Hokusai study, the patients who had a creatinine clearance of 30 to 40, they had a dose reduction of edoxaban to 30 milligrams, so half the usual therapeutic dose. And they still had a higher risk of bleeding compared to full dose low molecular weight heparin. So I am a bit concerned about using the direct oral anticoagulants in patients with even more renal impairment. Just looking at this, again, very preliminary, small numbers of patients, but I am very concerned. So I would not be using direct oral anticoagulants in cancer patients with such bad renal function.
That's great. Thank you. I'm just going to open it up for any questions to the audience. Just unmute your phone and feel free to ask. And while I'm waiting, one last question for myself. Just in terms of the duration of anticoagulation for a cancer-associated thrombosis, clot was a 6-month time period. And basically, because of that, I think a lot of people's practices are to treat for 6 months and then reassess and then continue anticoagulation if, there's no bleeding and the cancer is still active or they're receiving chemo. But the algorithm suggests that, maybe we should be individualizing therapy further and just reassessing every 3 months in everybody. Is the initial 6-month period, not really necessary anymore in your opinion? And can we get away with shorter periods of treatment if the cancer is cured?
Yeah, so when we designed the clot study many, many years ago, we picked 6 months mainly because when we see patients with cancer-associated thrombosis, it's often during that first 3 months and when they are starting chemotherapy, and for most chemotherapeutic regimens, 6 cycles is kind of the standard. So that's how we actually decided that, well, let's do 6 months, because if we're going to continue doing chemotherapy anyways, most patients are going to be on chemo for the next 6 months. And even after finishing chemo, there's still, you still need to wait to see if, for reassessment in terms of disease response. So that was really an empiric sort of duration that we picked. So I think you're right in that we really should be just looking at patients at 3 months, because that seems to be, the standard minimal duration of anticoagulation. So when I see patients now, I always say, you need a minimum of 3 months, and then we'll look at it, and we'll see what's happening at the 3-month mark. So if at 3 months you are no longer on chemotherapy, you have no residual evidence of cancer, you don't have, metastatic disease or relapse disease, that sort of thing, then I definitely will consider stopping anticoagulation. But I always discuss this with the patients, and so again, I do individualize treatment. So I do not always put everybody through 6 months of anticoagulant therapy.
That's great. Thank you. Okay. And are there any other questions from the group? Make sure you unmute your phone. Okay. Well, great. Well, I think with that, David, I think we are. I can turn it over to you, but I think we're good. Thank you to Aggie for such a great talk. Oh, sorry, there's one question here.
Yes, please. We've got one question. Just give me 1 second. Sorry. Thank you.
That's okay.
My name is Ursula Jarofska. I'm a medical oncologist at St. Joe. I'm curious, in terms of the guidelines, there's for patients with significant GI surgery, what's considered significant GI surgery? For example, anyone who's had colon cancer surgery, or I guess that's probably the patient population basically that. It's a large population for patients who have had colon cancer surgery. The primary tumor is removed, but they have had colon cancer surgery. Are they candidates for DOACs?
Yeah, so when we say GI surgery, I think we probably should have been more specific and talk about upper GI surgery, and that's because DOACs are primarily absorbed in the upper GI tract, right? So it's starting basically from the stomach and the duodenum, and so I'm not aware of a significant absorption in the, in distal colon sort of thing. And perhaps, people have thought this is why we see upper GI bleeding as being the predominant site, because there's a high concentration of the active drug in that area. So if the patient, say, had Whipple's, if the patient had, a gastrectomy or lots of upper GI problems, cholangiocarcinoma, then that's the group that we're most concerned with. And whereas, standard colorectal surgery, where resection of the large, even a partial hemicolectomy, it's probably reasonable, and there shouldn't be any significant interference in terms of drug absorption. But that data is not really published yet. But I know there's been, there are studies ongoing looking at patients, say, for example, who's undergone bariatric surgery, where clearly, their upper GI tract is different and removed. So that's the GI surgery that we're most concerned about.
Great.
Thank you.
No, you're welcome.
And any other questions? Okay. Well, with that, I'd like to thank Dr. Lee again for such a comprehensive presentation. And David, any final words?
On behalf of Thrombosis Canada, I'd like to thank both you, Sudeep, and Agnes for today's presentation, and appreciate everybody's participation, and look forward to further programs.
Thank you very much, everyone.
Thanks a lot. Have a great day.
Okay, bye-bye.
Bye.